Good morning, everyone. It is September 27th, 9 a.m. This is MED120 for DAX, and this is week 9. Next week will be week 10. We don't have a Zoom session next week, but we have at the same time on October 4th, we have a final written examination. The final written examination will be 50 items, multiple choice. It will be done in the same format that you've been doing your discussions. So there'll be a little bit of a case, and where am I getting the cases from? I'm getting them directly from any chapter that you've ever had in this textbook. So it could be any chapter, and it'll be done in pretty much the same way you guys have been doing your quizzes. It'll be medical terminology questions, but in the format of looking at an actual case. Of course, it is week 9. Week 8 items are due, which is, of course, your medical language laboratory, your discussion, which is the make your own quiz assignment, and, of course, your medical language laboratory. I'm probably a week behind on medical language laboratory, but I have some people catching up, so that's why I'm kind of holding grades a little bit. But grades by 11, 10, 9, they have to be posted by the 9th at 12 noon. So please, late is better than nothing. But I don't think anybody on this call right now is in any jeopardy. So just keep on doing what you're doing, and look at the cases at the end of every chapter that we've done. And this week, we got 2 chapters, the integumentary system and the eye and ear. And I still to this day don't know why the curriculum committee put chapter 3 all the way in the back. But that's probably going to change, but it is. So we'll go over the skin, chapter 3, and then eye and ear, which is chapter 11. So let's jump right down to what's going on. The wrong thing. Chapter 3, which is integumentary system. And many of you already did the integumentary system on your medical language laboratory, so good on you. The only thing you got to do for this week is 11. And those of you who did it already, I already gave you credit. So good. So dermatology, logi, the study of skin. It is skin's is not just a covering. It's a pretty complicated covering that we have, and like many of the coverings in our human body, there's layers. Now, if you use your medical terminology powers, if you look at the layers, epidermis, dermis, and subcutaneous tissue, the prefix epi means right on top of. So the epidermis has to be the upper layer. The dermis, of course, is the main layer. This has a lot of the juicy things like nerves and arteries and veins. And your subcutaneous tissue. Sub means under. Cutaneous is another word for skin. So underneath the main layer, which is the dermis, right? Sometimes they call it subdermal. Sometimes there's also a little bit of slang that calls it sub-Q. That's a nice little, what do you call it? Little slang for subcutaneous tissue. And you could also see a lot of the subcutaneous tissue has fat. And we're going to be looking at that word fat. Oh, here it is. It's another word for fat, which is adipose tissue. Okay, so let's jump right in. Another word for fat, adipose, lipids, steat, which is another root word for fat. You have adipoceles, which is any herniation or anything that's sticking out that shouldn't be sticking out, and that's what a hernia is. And you can have an adipocele. Lipocyte is the fat cell. Adipocyte is another term for fat cell. Steatitis, inflammation or infection of fatty tissue, because fat even though it's a nice insulator, and it's just like everything in our human body. It's a living thing that can be infected, and that's called steatitis. Cutaneous tissue, we already learned that in the word subcutaneous, so it's underneath the skin. Dermatology, the study of skin. Dermatologist is the specialist or the professional. And a dermatologist, they are an MD. So they went to medical school. And then they did, I forgot if it's 3 or 4 years now. It used to be 3, dermatology subspecialty for residency. Hypodermic, it's a needle that goes hypo, underneath your skin. Hidradenitis, inflammation or infection of your sweat glands. Adeno, gland, hydr, sweat. Hydro is water, but sweat is water and some other stuff. So hydro, H-I-D-R-O, sweat. Hydro, H-Y-D-R-O, water. Doesn't that look like a beautiful both A and B question that I could try to confuse you with? Hint, hint. Pseudoresis. That's esis is like an osis. It's an abnormal condition of sudor, profuse sweating, not normal sweating. They also call it diaphoresis and hyperhidrosis. It's the kind of sweating that you get if you've ever had like a really high fever and then your fever broke and it feels like someone poured water over your head in from a glass. That's what diaphoresis, hyperhidrosis, and pseudoresis looks like. And if you just have it for no reason, we start looking at neurologic reasons why you're having it. But typically, it's usually in response to hyperthermia or some high fever state. Ichthyosis, osis, abnormal condition. Ichthy. Ichthy actually means fish in Latin, and it means dry, scaly skin. Ichthyosis. Okay. Now, keratosis, skin is supposed to be pliable and soft. Once it starts hardening up, that's not a good thing. Or overgrowth or thickening, it's not a good thing. Because remember, we need to be in balance. You can't have super thick skin, nor can you have super thin skin. It has to be nice and balanced. And keratosis is an imbalance. It is a thickening of the skin. Melanoma, we know oma means tumor, and tumor means lump or bump. Melan is the color of the tumor. It's actually dark brown, but you just look at it, really quick. It looks more black. But if you look really, really close, melanoma is like really, really dark brown. And you have melanocytes that protect you against UV radiation tumors of the sun, right? And melanoma is one of those tumors. Myco, fungal infection. So if I had a dermatomycosis, osis, abnormal condition of fungus, dermat is in my skin. You can more commonly fungal infection, onychomycosis. Let me write that down. If you go to a sketchy nail place, that is why the nails. Well, in Virginia, it's nail places are regulated by Board of Nursing, last time I recall, and the Department of Health, of course. So onycho means nails. So if I had onychomycosis, that is something more specific. I have a fungal infection in my nails. Very common if you go to a sketchy nail place. And dermatomycosis, abnormal condition of skin fungus. Now, a lot of times in medical, we think fungus. I think my patient's immunocompromised somehow, because fungus don't usually grow. And if your immune system is down, then they start growing out of hand. Ooh. That's my little man. He's 4 today. Wait a minute.
Oh, happy birthday to him.
Thank you. I love the fact that he's in school. I don't have to deal with him at least for a couple of hours. And then the craziness begins later. What was I doing? All right, here. Pylo. Pylo is hair. Piloneedle cyst. Need, N-I-D, that's a nest. Now, a cyst, of course, is, remember, if you have like an infection, the white blood cells and the pus is made out of white blood cell, dead white blood cells, and dead bacteria. And you could have a whole bunch of hair tangled up in that as well. And that's called a piloneedle cyst, right? Trichopathy, that's any pathology or any disease state of your hair. And you will most likely, the most common sign that you have a trichopathy is either you're growing too much hair, and that's called hirsutism. Let's write that down. Yeah, too much hair. And you could get that from certain chemicals and certain hormones and certain medications. So if you're a woman, you shouldn't be growing a beard. But you, in hirsutism, you won't grow a beard, but you'll start growing facial hair where you didn't have facial hair before. And then too little growth or balding, and that could also happen in women as well. That's called alopecia or alopecia, potato. Okay, hirsutism, too much hair growth. Alopecia, that's when your hair starts falling out. And there, I gotta keep on remembering it's Firefox down here. Another hardening of your skin is scleroderma. Okay, where's the other hardening? Keratosis. So wouldn't that be a beautiful both A and B question? Squamous. Squamous are scales or scale-like cells. It's not really scales, but it's like, yeah, it's scales. Let me show you what squamous cells in the skin look like. This is the top part of your skin, and it looks like there's layers. And on the very, very top part, that's where you got dead skin cells. And that's why you get ashy from time to time, because this stuff starts flaking off. And it's really neat because the ones on the top are dead, form a protective layer for the new ones that are down here that are living. And those are squamous cells. And they're flat, scale, and they form like a protective layer in your epidermis. Xeroderma, it is a mild form of ichthyosis, chronic dry skin, or excessive roughness and dryness in your skin. Derma, of course, skin. Pyo is pus, and we already know that pus is dead white blood cells and dead bacteria. You put them together, you got pus, and you really should get rid of that because dead things beget more dead things in the body. That's why if you have any necrotic tissue or dead and dying tissue, we try to remove as much as possible because that dead and dying tissue is going to start signaling the other tissues, the live, viable tissues, and it's going to start signaling them through tumor necrosis factor. It's going to say, hey, I'm dead. You guys should join us. We should all just die. And that's why we have to get rid of necrotic tissue or dead tissue. Dermoid. So dermoid cyst looks like skin, but it isn't. And same thing in the case of that piloneedle cyst that we just mentioned. It looks like skin, it looks like hair, but it isn't. That's why the term, the suffix oid means resembling. Diaphoresis, we already talked about that. That means pseudoresis or hyperhidrosis, condition of excessive or profuse sweating. Dermatoplasty, surgical repair of the skin or skin grafting. We expand parts of your skin, most likely in your back and your butt, and then we take and remove that skin, especially for burn patients, and then we apply it on the affected areas. Cryotherapy, That's when we use extreme cold, most likely in the form of there's these little match things. Let's look at cryotherapy. No, that's not the correct. This is weirdo therapy. I don't know what people going in these cold chambers, but for skin, there you go. So we use like chemicals, and we ice up an area. So if you look at this, if I ice up an area, like let's say this is a little small tumor, I ice up this area, I could pull all this out, and then we remove all this out, and it performs a nice little layer there. And this is in the form of I forgot the name of the chemical we used, but this is how we do it. See how it gets super, super cold, and then we just pluck it out. And also there are, just be careful when you have any chemicals. There's also another type of chemical stick that we use. It looks like a match, but it has a blue head on it, and it's usually in some sort of test tube type thing. It does the same thing. Be careful. I made the mistake of holding one by accident, and it burned a piece of my skin right off when I was a medical assistant. Because again, wasn't paying attention, didn't wear my gloves, and it hurt. Dermat, we already went over. Melano, that's good. Let's see if there's any other. Now, liposuction, I'm not a fan of it, because the very fact that you're sticking this huge needle and it's called a trocar, it's like it's like the size of your, I don't know, like a really thick pencil. And that's the last thing you want jabbing into your skin. And we jab it into a hole in your skin. Usually in the front, we usually create that hole near your umbilical cord so it doesn't show any sightly stuff. But removing all the fat in your body, the remaining fat cells do a very interesting thing. Since they detect that there's less fat cells, they start expanding. So that diet that you had before you had liposuction, it better be continued long after the liposuction. And pretty much you could look up the statistics, but I believe like 39% gain the weight back within 1 year. And for every year after post-procedure, the weight gain gets bigger and bigger. It's like, so for year 2, it's 52%, year 3, 64%. So the best way, I believe medically, the only way to deal with obesity is you must change your lifestyle. If you don't work out, start working out. If you don't eat salad, start eating salad. If you smoke, stop. If you drink, stop. And I read a very interesting article last night. National Institute of Health, I get these updates. There is a direct correlation with your sleeping patterns and obesity. And also, if you're one of these kind of people who have to take a nap in the afternoon, I'm one of them. It has a direct correlation with obesity, and we already know that obesity has a direct correlation with kidney disease, diabetes, and heart disease. What else? Kerato, we went over. A comedone or a comedo or a pustule. Sebum is oil, is natural oil in your skin. But you know, if you got way too much oil, then you get zits, and then you get zits. It's the backup of all that sebum, and you know when you pop them, the little pebbles that come out, that's called a comedone, comedo. And then when they get infected, the pus comes out. That's a pustule. That's never a good thing. Tricho, we already went over. This is onycho. This is your nail. Onycho nail. So onychomycosis is an abnormal condition of nail fungus. So make sure when you go to your nail joint that they are clean and they have all the little certificates on the wall. Here's a little nice chart outlining colors. So albinism is a condition of white skin. These patients don't have any melanin, therefore they have nothing to protect them from the sun and UV radiation. And they also come with extreme anemia because remember, your skin must be exposed to sunlight so it can process vitamin D. Cyano means blue. So if my patient oxygen status isn't good, they will form Scleroderma. It's like a bluish or bluish grayish discoloration of your skin. Erythro is red, erythroderma. So if you get flushed or get flustered or even get some medication and you get an allergic reaction, you could have erythroderma. Leukoderma, white skin, leuko, white, or it's paler than usual. Melano, black skin. A melanoma is a tumor that is black or dark brown in color. A xanthoma is usually this abnormal accumulation of fat and steatitis, which is inflammation or infection of your fat, and it's yellow. And a xanthoma, you could see it's weeping, and it looks like it's weeping sweat, but it's actually fat. That's in a bad way. That person probably has hyperlipidemia of the type 1A variety, which is familial or genetic. Cytology, of course. If I take a skin scraping, I have to send it to the Department of Pathology. But the specific department within the Department of Pathology that looks at the skin scraping is, there's two departments, cytology and histology. Let me write that down. So in the Department of Pathology, of course, they're the department that knows everything about disease. They also do all the diagnostic testing, like biopsies and so on and so forth. So if I send a biopsy, right, let's say, for example, like a pap smear, which is a bunch of cells, I'm, of course, going to send that to the Department of Cytology. Cyto, cell, logi, study of. Now, if I have a Woods light sample, it's like a special UV radiation light, and then we do scrapings. We do a skin scraping, or a little bit of a skin biopsy. Then I have to send that to the Department of Pathology, and the subsection Department of Histology will take a look at it. And histo means tissue. You glue a whole bunch of cells together and you form tissues, which is histo. So that's histology. Okay. Ooh, why doesn't it keep it open? Okay. Oh, here's one. Leukocytopenia. Now, penia is anything that means a decrease or a deficiency. So if I had erythrocytopenia, that means my red blood cells are not good. If I had leukocytopenia, that means my white blood cells are either decreased or deficient. And if I've had thrombocytopenia, that means my thrombocytes or my platelets are in deficiency. That's a nice comparison there. EMEA. So that's what EMEA is. Let's look at EMEA. So that's a common thing that comes out. So the suffix EMEA, that means blood condition. So if my patient has anemia, they have a blood condition of no or not. That means there is a significant deficiency versus something like leukocytopenia, which just could mean just a deficiency or a decrease. But when you have an anemia, it's a significant deficiency because you can't have no blood at all, but it can be so low that functionally it's not working for you, and that's anemia. Deficiency or decrease of WBC, white blood cells. Erythrocytopenia, think RBC, red blood cells. And platelets is thrombocytopenia, which is platelets, also known as thrombocytes. And of course, you got thrombocytopenia, what's going to happen? Our patient's going to start bleeding. That's not a good thing. Right? Now, of course, when I do stuff like that, kindly, when you rewatch the video, pause and soak it in, and then ask yourself, doesn't that look like a beautiful way that Dr. Garais can ask the question? And here's an example of malignant melanoma. You see this is like all black, but if you look here on the edges, let's see if I can get a little closer. It's like a dark, dark brown. And then you put it all together, and you can see it's on the bridge of this man's nose, which is a sun-exposed area. And you could see this patient of ours is Caucasian, which is a risk factor because the lighter the skin, the less melanin, you can't protect the skin as well against UV radiation against the sunlight. So if you're a fairer-skinned person, well, even if you are a darker-skinned person, you shouldn't really be outside too much without either protective covering or, but if you have sunblock. But if you have less melanin, less melanocytes in your body, you're going to have a predisposition to these cancers. Oh, I mentioned necrotic tissue, necrosis, osis, abnormal condition of Necker, death, and gangrene is a form of that. And we want to try to prevent gangrene because that's the spreading of dead tissue. And that's no bueno in the Department of Surgery. Get very excited about that. AIDS, BCC, basal cell carcinoma, very common. BX, capital B with a lowercase x is biopsy. I've never seen it written like that. Diagnosis is capital D with a lowercase x. Prognosis is a capital P with a lowercase x. Dermatology, we call derma, and that's the slang. It's like the way we call neurology, neuro, cardiology, cardio, nephrology, nephro. Family history, yeah, you have family history, FH, PMH, past medical history. There's a whole bunch of things. I and D is incision and drainage. There's more of incision and drainage than irrigation and debridement. And debridement is the process of cutting away necrotic tissue. And or scrubbing it away. Oh, that's ultra painful. PE is physical examination. I've seen it sometimes called pulmonary embolism, but PE is the most common term of physical examination. So you have your interview, you interview your patient, and that's for the history, right? And history is capitalized, capital H with a lowercase x. So you have family history, past medical history, social history, genetic history. There's you'll learn that when you're in your medical search. Disease and conditions, nah. You learn that in other classes, so I'm not going to do that part. And of course, why do I keep on doing that? At the very end, of course, are cases that you could look at, and then you will also be responsible for. Let me look at them real quick. This is how you do it. I can go. How do I do this? this. This. Ah, they don't want to. Gotta do it like this, and hopefully there. So again, here's an example of a case. I'd ask a question, medical terminology question based on the case. So for example, the consultation letter of dermatology and cosmetic surgery. So Dr. Liu has to be a what? Dermatologist. Okay, why are we seeing this patient, right? Presented for a skin cancer check. So they're there for what they call a screening. Now, skin cancer check screening, we screen people who are asymptomatic. So they could have it or they couldn't have it, but we look just to make sure, right? And I guess our patient spends considerable time in the sun, no family history, right? No FH, no PMH, past medical history of skin cancer. Changes of idiopathic I forgot how to pronounce that, guttate hypomelanosis. Idiopathic means, idio means I don't know where I got it from. Patho, of course, disease. So an idiopathic disease, it's called a garbage can diagnosis or a diagnosis of exclusion. Meaning to say is we checked everything and we don't have any other answer to why her skin has hypomelanosis. Hypo meaning decreased, melanin, dark. So maybe she's a skin of color and she has these light patches over her legs, and they're calling it idiopathic hypomelanosis. She also has seborrheic keratosis. So I could ask you, that keratosis, is it hardening, softening, both, neither? Where was it? Left, right, up, down, right? She also has a tumor. It's called a cherry angioma. It's a benign tumor. And it's all over her left thigh as well. I could ask where? Left, right, up, down. When we're going through a skin cancer check, what do? Sun exposed sites, because I want to see if there's any UV radiation damage over sun exposed areas. And we found a pigmented, meaning it's colored, solar keratosis, solar pertaining to the sun, hardening over her right zygoma, which is her cheekbone. Numerous excoriated acne lesions. Now, excoriations are when you scratch your face, it's still itchy and you have a scratch, and you keep on scratching it because it's itchy or because it bothers you. Photoprotection. Photo is another term for sun. And what did we do? It's a precancerous lesion, so I did cryotherapy, utilized liquid nitrogen on an applicator, either dry or wet. Okay, and Mrs. Mears, is she scheduled to return anytime soon? Nope, as needed. Meaning to say is if her symptoms persist or come back, or if she has any wound healing problems over the cryotherapy that we did for her. So you could see how I could easily start asking questions, and I could also start utilizing the questions that are in the back of your book. Some of you are clever. You guys took some of these questions and actually made them into multiple choice exam questions for your discussions. Smart move, because hint, hint, guess what I did for the exam? Same exact thing. So you guys could look at this as well. I could ask you the diagnosis. I could ask you what was found on the PE. What was the history? 23-year-old Caucasian female. Intermittent psoriasis means that it came and went. Severity goes various severity since her early teens. So this is a chronic condition. Okay. Pruritus is itching that's beyond itching. Ever have an itch that it's so bad that even if you have cuts, even if you have excoriations, you still scratch at it? And that is what is called a pruritus. It's really bad. It's super itching to the point where it drives you a little bit nuts. Okay, let's now look at chapter 11, which is our eyes and ears. Now they call it special sense, and the sensory has a lot of subspecialties. So for the eyes, the MD that looks at your eyes, and that is also a medical and surgical service, and that's the Department of Ophthalmology. Now your optometrist and your optician, they are not MDs, but they're just as important, because your optometrist makes sure your lenses your lenses are good, and the optician is the one that builds the lenses. So they have specialized training, but the clinical aspect is the MD, that's ophthalmologist. So optometrist, right, and optician, they are not MDs, but they also can do a basic test for vision, and also the advanced test for visions, but they can't diagnose stuff the same way that the ophthalmologist does. Otorhinolaryngology, or otolaryngology, ENT. Let's write that one down, because that's a 25-cent word. Auto, break it down. Rhinolaryngology. Study of otto, which is your ears, rhino, which is your nose, and laryngology, your larynx, or your throat. Well, actually, your larynx is your waste box, to be specific. But that also includes your pharynx, which is your, of course. So the Department of ENT, ears, nose, and throat, or otorhinolaryngology. They are both a medical and surgical service, so they also do surgeries. And their specialties are ears, nose, and throat. Okay, that's what they call ENT. Now, if you have a specialist who's trying to evaluate your hearing loss, that's the audiologist. They are not an MD, but they have a 4-year degree, and they just like the optometrists and the opticians, they do basic ear testing, and also they're the ones that do also the follow-up for treatments in hearing loss. So, eyes. Your eyelid, blepharo. So if your eyelid starts twitching about because it has muscles in it, that's involuntary contractions, and that's called a blepharospasm. You can have an involuntary contraction, a little bit jiggly, like sometimes your toe, or me, it's like the back of my arm where my tricep is. It's just like I'm at dinner and it just randomly starts contracting. It's not painful, it's just weird and annoying. Conjunctiva. Okay, the conjunctiva is like the white parts of your eye, and if that gets infected, you could have bacterial conjunctivitis, which is, by the way, bacterial conjunctivitis is highly infectious. So if your kids have it, you try to separate them from the other kids or your other family members, because if your kid gets pink eye, they start rubbing their eye, then they hug you, then they touch your face or touch your hand, and then you touch your face, and bingo, you have conjunctivitis too. Choroidopathy. Say that 10 times fast. Choroidopathy, that's inflammation or infection of the vascular layer of the eye. Now, in the back of your eye, you have something called your retina. Your retina is the cameras or the sensors that pick up light and then convert those light rays into information that the brain can read in the form of little bits of electricity. If that choroid starts getting inflamed, you're going to have some neurologic problems, and also you're going to have some problems with your vision. Your cornea is the clear layer or right before your lens. And if that gets inflamed or if that gets scratched up, you can get corneitis, also known as keratitis. Anisocoria is when aniso means unequal. Now, typically, if I in a dark room, if I flashed a pen light in one of your eyes, both of your eyes should react, okay? And that's perla, pupils equal and reactive to light and accommodation. But if that doesn't happen, it could be a signal of brain damage or spinal cord damage, and that's called anisocoria. That's never a good thing. It means there's a neurological problem somewhere. Choriometer, measurement for measuring that the eye. But if you look at the side of most pen lights, they have these circles with, and it'll like say 8 millimeter, 9 millimeter, 7 millimeter. Those are, you use that as a choriometer to see how big pupils are. Of course, pupillary constriction. That's what happens when I flash a light. If you're in a dark room, your pupils should be wide open so you could see all the light rays. But then if I flash light rays, excess amount of light in your eyes, your pupils will naturally close up because, you know, it's not only irritating, but it doesn't need all that light. Dacryuria, excessive secretion of tears. Lacrimation, secretion, discharge of tears. And tears are important because they're not only just water, there's enzymes in it to break down bacteria. Diplopia, that's double vision. Di means two, so diplopia means double vision. Iridoplasia, remember paralysis. Now your iris is part of the opening that also belongs to your pupil. And if you have iridoplasia, the muscles there on the inside part of your eye that control the lens and all that stuff is probably paralyzed. And sometimes we do that on purpose so that we can do we can look at your eye through a slit lamp, and we're going to show you what that machine is in a moment. Keratoplasty, the cornea is the hard outside layer of your eye. It's for protection, and if it gets damaged or cut, we must perform a keratoplasty. Most likely it's foreign body. You know, a lot of people who do, you know, chores around the house or whatever, especially if you're doing a little light carpentry or whatever, wear goggles, because how many times I have to, well, when I was an ENT, you got to pull that stuff out of their eye and it becomes minor surgery to major surgery. It's a pain. Intraocular or IOP or intraocular pressure. Glaucoma is a disease where your IOP or your intraocular pressure or the pressure within your eyeball gets too much, and it is a major cause of preventable blindness. But the number one major cause of preventable blindness is diabetic retinopathy. You have uncontrolled diabetes and you don't do anything about it, in less than 5 years, you will be legally blind if you don't do anything about it. My father, when he was alive, was one of those people, and almost on cue. It was like 4.5 years into his uncontrolled diabetes, because he's stubborn. He started having retinopathies. Retina, it is those cameras in the back of your eye, and if you have this pathy or disease of it, or a disease state, that's a problem. Optic nerve, of course, is the cranial nerve 2 that connects your eye to your brain. Optic. Just like on a rifle, your optics are your scope, the thing that you see through. Scleritis, inflammation or infection of the sclera, right, which is part of the whites of your eyes. So you can also have scleritis, inflammation or infection of that area. Amblyopia, Opia means a type of vision. So amblyopia is you have already reduction of vision, but only in one eye. The other eye is okay. Heteropsia is the resulting inequality of vision within the two eyes. For example, my left eye is really bad. My right eye, not so. So if I close my left eye and walk around with only my right eye, I'm all right. I close my right eye, I'm doing it right now. Without my glasses, I can't see a thing. It's just blurry city. Blepharoptosis, we already know that blepharo is your eyelid. And if you're on drugs or if you're tired or if you have a neurologic, your upper eyelid will start drooping. Hypertropia, okay? Tropia is turning. So hypertropia is the excessive turning of your eye, also known as strabismus or your ocular deviation. There's another term called esotropia, and that's when you have like cross-eyed. Again, that's ocular deviation. Conjunctivitis. Am I on time? Oh, okay. Okay. And here's the lovely parts of your eye. What am I doing now? Oh, this is neat. You could do flashcards, apparently. Never use that. This is wonderful if you have anatomy and physiology too. And the retina is this part. See this yellow part in the back of your eye? And you see that layer of all those arteries and veins. If that's getting infected, this is going to get infected. And this is your cranial nerve 2, which is your optic nerve. Don't want to get into the other parts because I don't want this to devolve into anatomy or evolve, not devolve. Devolve connotes that it's falling apart. Evolve meaning to change. Evil, the term. Ophthalmologist. Now, do you see what the ophthalmologist is doing, right? This is ophthalmoscope. Right eye meets her right eye. So because if right eye meets left eye, then there's a potential for the lips to meet, and that's called a lawsuit in medical, right? And you could also see how he's also bracing the patient this way. I also like putting my finger like here so that this thing doesn't bump into our eyeball. Learn all this stuff when you're in your clinical classes. But of course, this is just so that you can know what the doctor's doing if ever you assist. And this is your basic eye physical examination or ocular PE. As they say in the biz, opia, diplopia, we weren't even running over that. Oh, emetropia is normal vision, meaning to say is when you see something, the light rays are going to fall right on the retina, also known as your focal point. And it's good. Don't need glasses. You're good. But if you're myopic, you're nearsighted, the image falls short, right? And goes if you're hyperopic or farsighted, the image falls behind the retina, and that's not a good thing. And if you have astigmatism, I have this, you'll notice the shape of the eyeball is a little bit more egg-like than it is round. And then you'll have really fuzzy vision because then you're going to have some of the vision is going to be nearsighted, some of it's farsighted, and some of it may even fall right on the retina itself. That's why when I close my right eye, I have astigmatism left. Depending on how I'm looking at things, I could be nearsighted, farsighted, and everything in between. Lacrimal gland, lacrimal duct. Your tears come from here and then they wash over here. Now, when you cry is when this gets too much and can't empty out, and then tear rolls down your face. And then also, now that excess fluid goes in here, and then you get the sniffles and you need some tissue. Acoustic, pertaining to hearing. Audiometer is an instrument that will measure your hearing in the Department of Audiology, where they will perform an auditory hearing test. Tympanic membrane, which is your eardrum. So sometimes I have to cut it because it's damaged. That's a myrigotomy. And then I perform something called a tympanoplasty, which will repair my eardrum or the patient's eardrum. Auto, we already know, autourea, inflammation with purulent discharge. The word purulent means that it smells. Okay, you can definitely smell it. It's not, I don't know how to describe it. It's just funky, right? Now, if you see clear fluid that's non-smelling, inform your chain of command immediately. It could be cerebrospinal fluid. I had a case where I had the resident above me. He let go a kid who fell. He fell off the swings or whatever, and he had noticeable discharge coming out from one of his ears, but it wasn't purulent. It was clear, and he just cleaned it up, sent him on his way. Kid came back to the ER, and that's where I met him. He was in a coma. Right, so autourea, inflammation, or in otitis, right? That typical discharge is purulent. It smells, and it's also greasy, and it's just gross. But if it's clear and it doesn't smell, and it's coming out of your nose or coming out of your ears, inform your chain of command immediately. If it's postnasal drip, if you actually get close enough to smell the stuff that comes out of your kid's nose, it stinks. It's smelly. It's purulent. Salpingo pharyngeal. Now, your salpingo in the world of ENT are your eustachian tubes or eustachian tubes, potato. Eustachian tube is the tube that connects your ear to your throat. That's why when you get otitis media, you usually get it from, it starts as a sore throat and then it ends up becoming an earache. Hence the term otitis media, because the middle to inner part of your ear has this tube that's used to, offset the pressures between your mouth and your ears. That's why your ears pop when you go in an airplane, and that's your eustachian tube, also known as salpingo. So if I had salpingitis in the Department of ENT, I'm not talking about your fallopian tubes. I'm talking about your eustachian auditory tubes that connect your middle ear to your throat or your pharyngeal area. Acusis is deafness. Anacusis, total deafness, can't hear anything. Hyperacusis, the patient has an acute sensitivity to sound, right? And hypo, it's not really a word, but anacusis and hyperacusis. And here, this is your external ear, middle ear, inner ear, and this is your eardrum, your three small ossicles or smallest bones in your body. This is your cochlea, and this is the vestibular cochlear nerve, cranial nerve 8. So when you hear things, blah, 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 my lecture, the eardrum starts vibrating. That vibration starts vibrating the three smallest bones in your body, your malleus, your incus, and your stapes. And then it goes through this thing called your oval window. And in the oval window, it connects right here to this thing called your cochlea. Your cochlea has this stuff called endolymph, endo meaning within, right? There's this fluid, and the fluid rattles because you're converting sound to mechanical energy, which is right here. It activates your cranial nerve 8, the vestibular portion of your the cochlear portion of your cranial nerve 8, and the vestibular portion here is your vestibule here. That deals with balance. That's why balance is inherently related to hearing. So that's inner ear. Here's the middle ear, which connects to your throat. otitis media, otitis, inflammation or infection of my ear, right? I have a sore throat. I didn't take care of it. The infection goes up here, then infects here. Then I have hearing problems. And then I could also have tinnitus, Tinnuti. Wait, am I spelling it correctly? Yeah, there it is. I could have tinnitus or the ringing, the buzzing or ringing in your ears. Ever go to a loud concert and the next morning you hear beep? That's tinnitus. Try not to get that. I have never-ending chronic tinnitus of my left ear because of 28 years of DJing and having a monitor, either a monitor speaker or a monitor or a headphone in my left ear. And they would look at me with an otoscope. Okay. And again, I try to put my hand here as a brace because what if my patient slips or I slip? Boop, that speculum is going to go right in his ear and cause damage. Oh, this is why your ears pop, because this is your eustachian tube, and it equalizes the pressure in your ears and in your throat. That's why when you're in a pain, you want your ears to pop and get that over with, swallow. That's why they say to chew gum or something like that when you're in the air. AMD, ARMD, that's kind of common. Age-related macular degeneration. It means that your macula, which is part of your retina in the back of your eyeball, it starts wearing away. And this is most likely due to age. I've never seen that. I've seen ECCE, extracapular cataract extraction. If your lenses get opaque and get clouded up, they have to do ECCE to remove that capsule that has the cataracts in it. Nowadays, we can even shave it with a laser. It's pretty neat. IOP, intraocular pressure. I've never seen IOL. IOP I've seen. Intravenous fluorescein angiography. We put a chemical where? In your veins, right? Via, via IV. And it has fluorescein in it, which glows in the dark. And when we look at your blood vessels in your eye, it'll light up and we could see it a little clearer. AC is air conduction, BC is bone conduction. That's when we do this thing. We do something called the Rene-Weber test. We hit the tuning fork, and then I put it on top of your head, and then I hit the tuning fork again, and then I put it on the back part of your mastoid process behind your ear. Then I hit the tuning fork again, and then I put it by your ear. And I'm checking bone conduction hearing versus air conduction hearing, okay? And if the air is greater than bone, then I have normal hearing. But if my patient hears it better with the bone conduction on this tuning fork, that means there's a conductive loss, okay? And the Weber test, you should be able to hear it on both sides. But if you hear it on one side but not the other, you have a sensory or a neural problem on the other side. So let's say, for example, my patient, I hit the tuning fork and then I put this on top of his head, and then the patient's supposed to tell me that both of them sound equal. But this patient, let's call him Dave, he only hears it here on his left side. That means he has right-sided sensory neural loss, and that means a potential problem. ENT, ears, nose, and throat. NIHL, noise-induced hearing loss. I've seen it once or twice. LASIK, see that all the time. Laser-assisted, in situ, keratomileusis. Now, what are we doing in LASIK? Again, laser, I'm taking light, and instead of using a scalpel, which can be dirty, I use a light, which is sterile, and it's easier, quicker. It's day surgery, and you'll be out same day. DO or OD. DO is different than OD. OD is the doctorate of optometry. And remember, DO is doctorate of osteopathy. Two different things. Perla, I mentioned, pupils equal, round, and reactive to light and accommodation. That's when I flash that flashlight in your eyes in the dark room, and both of your eyes together, the pupils contract. They contract at the same speed and the same size. RK and VA, visual acuity, sometimes. Otitis media, I've never seen that. PE, of course, physical examination. URI or URTI is upper respiratory tract infection or upper respiratory infection, which ENT are experts at. So that's your sinusitis, your rhinitis, pharyngitis, laryngitis, right? And those are the specialists you go to, especially if you're a singer. I'm not going to go over the, what's this called? Your pathologies. You'll have that when you're, of course, in pathology. I just want, oh, this is the thing I wanted to show you. This is a slit lamp. So we put chemicals in here to dilate your pupils so we could see to the sides and inside your eyeball. We do that because there's a whole bunch of things that the ophthalmologist can see that that normal ophthalmoscope won't see. And it's really, really good for diagnosing diabetic retinopathy, also chronic hypertension and hypertensive states. We look in the arteries and veins inside your eyeball. Now, tonometry, this is a different machine. A tonometry, maybe you've experienced it. You stick your head in the machine and it blows air into your eyeball to measure the intraocular pressure and to see if you're at risk for glaucoma. This is a Snellen's chart. Okay. 20/20 vision is here at the green. That means at 20 feet, you can read this line. That's why they call it 20/20 vision. This is a Rene Weber test, the bone conduction and the air conduction. I mean, yeah, Rene Weber. That's what it's called. Whoa, that's not good. Ear irrigation, that's never fun. Make sure you put towels everywhere. And this cerumen or this wax is very sticky and it smells. Anti-glaucoma agents, those are usually, well, just know it's anti-glaucoma. Their function is to decrease IOP. Miotics are causes pupil to constrict. Mydriatics is the exact opposite, dilate. The way I remember mydriatic versus miotic, it's a longer word. Longer word, dilated word, bigger pupil. Vertigo and motion sickness, remember, the inner ear also not only deals with hearing, it also deals with balance because of the vestibular cochlear nerve. So if you got a hearing problem, most likely it may be accompanied with motion sickness, also known as vertigo. But vertigo is it's an older word, but it's a more serious thing than just motion sickness. These people can't even stand up and then they get very, very sick. Emulsifier are things to remove impacted cerumen. The best wax emulsifier that you could use is hydrogen peroxide. I take a bowl here, and then of course I take like a 20 cc syringe without the needle, and then I flush it, and then of course you let it all come out. Now, worst comes to worst, we use hydrogen peroxide, and then if it still won't come out, we have vacuums for that. We have this mini vacuum that we can use. Ugh, give me the willies. I hated ENT. Ugh. Also, they were mean to me. That's medical school. They were always mean. Hey, why is this guy looking at me sus? Mr. Henry Holler? Right? Well, maybe because he has a pre-operative diagnosis of total retinal detachment. He probably can't see me in his left eye. And he had an initial bout of retinitis or inflammation or infection of his retina. And we tried to do a retinal repair, and that was the procedure. So I could ask questions about the procedure. Goes, how did we start? Did we do the Did we do the ECG first, or did we do the IV first? Of course, IV came first, then ECG. Then we gave anesthetic. Where? In the retrobulbar area of his eye. Good anesthesia and akinesia means kinesi means to move. So I have to also make sure your eyeballs don't move, because even when you're passed out, even when we give you anesthesia, your eyeballs move. And that's not good if I'm doing surgery on his eye. Suture, what other nice thing? What did we remove? Part of vitreous, which is the peripheral portion or the side portion. Your eyeball has two sections. It has an aqueous section and a vitreous section. The front part is aqueous, which is water, and then the back part is vitreous, which is like jelly. And sometimes we got to move a little bit out of it. All right. So, and who was the surgeon? This is an operative report. So Dr. Kanan did it. I could ask that. Who did it? What did they do? When did they do it? Where did they do it? Mary Strew. Okay. Of course, this is pediatric, and this is SOAP notes. Subjective, objective, assessment, and plan. Your subjective is most likely your histories. Objective is any physical examination and or laboratories that you did. That's included here, right? And assessment is the diagnosis. She had otitis media left, okay? And it's common for a little girl, okay? So we gave her amoxicillin. That was the antibiotic, also to deal with some of the pain and some of the fever. Tylenol, ibuprofen's good. Those are NSAIDs, non-steroidal anti-inflammatory drugs. And of course, follow-up, 2 weeks. Oh man, I would make it like 5 days. Once the fever go down, I think 5 days. But nowadays, we wouldn't ask her to come back physically, COVID and all, but we definitely follow up remotely. Okay. All right. Let me see if I have everybody. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. And it is this portion of the show that I will turn off